title, we have A New Horizon. This is the
I
name
love it.
for this presentation.
And what was the
So
title for the one before for Chase? What was the title? Did he give it
actually,
a title? I always encourage the fellows to give a title that is visionary, so that way it makes us imagine. This is a new, I like the New Horizon. Chase, did you have one title for yours?
I wasn't aware of the title, but I will come up with a good one on the next one, I promise.
Well, it's important because these things go in a video, a hub, and then you guys can put in your CV with the actual title, of something, so it catches attention. So good. All righty. Thank you. Go for it, Luisa.
Okay, let's rock and roll. So some of the acknowledgements of the whole team, these big CNAs that just take care of the patient. So everybody's just here, so I'm just gonna continue because of the sake of time. So the clinical presentation, we have a 47-year-old man with a previous history of a pituitary adenoma that was partially resected in 2017. That presents to the clinic with a partial blurriness and blindness on his right visual field. See, his past medical history is remarkable for a transsphenoidal subtotal resection, as I mentioned before. He presented with a transient PI after surgery, and at that time, he also was diagnosed with hypogonadism. The diagnosis at that moment was pituitary adenoma. The physical examination, he just presented with a right temporal field restriction. Otherwise, was unremarkable. Dr. Barsukova, I think you would like to comment.
Okay, he basically didn't really significant had, hyperfunction or hypersecretion of, pituitary axis. His cortisol at that time was, within appropriate range based on the time which was drawn, as well as no growth hormone deficiency either, acromegaly, no sense of secondary hypothyroidism. His ratio of SHLH didn't really suggest it, but he has a secreting gonadotroph, tumor. Normal, no sign of hyperprolactinemia as well. He did has a history of hypogonadism, which wasn't treated actually in the first place, but I probably was, after first surgery, but the baseline.
And I think that testosterone range below the bioavailable, the range given there is for free. So that's why it looks high, but it's actually the low end of normal.
You're talking about the bioavailable testosterone? Dr. Sampson, is that what you're referring to?
Yeah, I think the range given there is for free.
Yes.
But the actual level, the 50 is kind of low range normal for bioavailable. It just looked like it was very high, but it wasn't.
Gotcha.
Thank you very much. So the neuro-ophthalmologic examination, the one is going to tell us objectively what is going on in the visual field. This campimetry we can see in the right temporal field, both superior and inferior, an important compromise in his right temporal field. In the left, there is also a mild compromise. However, it's not as intense as it is in the right. Dr. Eckenberger is here in the call. I don't know, you would like to comment a little bit more here and also in the OCT.
So I think you're absolutely right. The right field looks diffusely affected, but mostly temporal. If you look at the tracing on the left visual field in the bottom, you can see that he does have a temporal hemianopia even in the left eye. So keep going down more. Okay, and here's his OCT. And his OCT of the macula on the left looks fine. You can see all the nerve fiber layer thinning that he has on his retinal nerve fiber layer in both eyes, mostly on the right, but also a bit on the left. So this speaks to prior optic nerve atrophy and decrease in nerve fiber layer from his prior compression.
Thank you, Dr. Eckenberger. So as I mentioned before, this patient had a previous surgery in 2017. So we want to know what was the initial state of this tumor, what happened after this subtotal resection, and what had been happening the rest of the day. So preoperatively, here we have an MRI showing us a lobulated, very important mass that it was also causing a mass effect in several structures. Just as a summarize, because we're going to go to the most recent images. After the surgery, we can tell that it was a decrease on this mass effect. Also, that is compatible with the clinic of the patient, that also his visual field and his symptoms just start to decrease. In 2017, it was a very slight growth, but no symptoms at that time. However, when he came to clinic, then we have our images. I have the September 21st, even though he was in the clinic in August, because this is the most recent one, pre-operative. So in this coronal view, I'm just gonna start scrolling. Just keep in mind how it was before. Now we can see how this mass has been growing and expanding. So the most important, I want to highlight here the optic nerve that is very thin, that is also consistent with the findings in the OCT. And also that suggests something chronic. The compromise of both cavernous sinus, most in the left, also in the right. In the left, I want to highlight now the shades also show us the NOFS grade. This is a grade 4 because it's encasing in the left, the ICA. So I know that JP would love to comment on this, and this image is very particular. Also, Dr. Reiner, it will be a pleasure if you want to comment too.
Let's hear from Dr. Reiner first. I mean, I think I would classify as a grade 3 probably, but let's hear from Dr. Reiner first, and then I can share some points of view.
What I use for grade 4, I like to see that inferior venous sulcus invaded as well. And yeah, I agree. That lower, the more proximal ICA is not completely surrounded. It's pretty close though. I would absolutely call this cavernous sinus invasion, and probably a low grade 4. And that sounds like I'm trying to avoid the question, but some of these criteria we use are really subjective. And so I probably would call this a high 3, low 4, which is a kind of a weasel way out of it. By the way, I just want to say that in my professional career, I never, ever anticipated we would be operating on the cavernous sinus. This is for people who are younger. This is just, you cannot believe the advancements we've got in neurosurgery, especially here at Mayo. This is extraordinary.
Agreed.
Thank you, Pat. This is beautiful. That's what I was saying. Very few people in the world. I can probably count with one hand the people in the world that are doing this kind of surgery. And I think that JP has pushed us in ways that I also, never thought that it would be possible. I was not getting into the cavernous sinus, and I was just telling JP that with him, I have gotten so comfortable that I was in Mexico doing a surgery just a couple of weeks ago. And we got into the cavernous sinus, and I felt so comfortable. Whereas before I started working with JP, I would have been completely freaking out, and running away from the room. But it is amazing, beautiful dissections, and I think that we're about to see another one right here. So let's see what's up.
Yeah, no, thank you very much for the comments. I mean, I appreciate. I think that it really takes a village. So for me, it's of course it feels very good to hear all the comments, and I appreciate that. But I think it's the team. Always is the team. So I'm very thankful for the opportunity to be here, and for everybody that helps us to be in this way. But I just want to bring one comment to the if you move in the coronal one, go back a bit. Yes, stop right there. But okay, so you see the reason why I think was important to look at the previous scans. It's kind of like in terms of tumor and skull base, you always think, where is the tumor coming from, right? Is it coming from the dura? Is it coming from the gland? Is it coming from the nerve? Is it coming from a vessel, and then you go from there. So in this case, the reason why in preparation for the surgery, we had to look at the first surgery, even the image before the first surgery, when the tumor is still virgin. And when you do that, you see that the tumor on the first coronal image did have a lateral inferior extension into the cavernous sinus. And that's where the component that the previous operative team didn't have a really chance to resect much. And when you look at this new MRI here and the patterns of growth, it's almost like you can identify 2 little balls of tumor. This one, and I had the impression that the medial wall had been pushed from lateral to medial by the tumor that had encased in the cavernous sinus, and a second component that had been partially resected that is respecting the cavernous sinus on the right side. That is this one that is going into the suprasellar space and compressing the right optic nerve. So when we think about those two components, we got to think about how we're going to safely maximize the resection. So this one, we have to go for the cavernous sinus, and this one we have to resect and decompress the suprasellar component. So we don't go to this component first. This is the second part of the surgery, and we have to attack this component first as the number one part of the surgery. Because if we attack this first, the arachnoid is going to be falling into us, and we're going to have to deal with arachnoid, CSF leak, and so on and so forth. We have to take advantage of the capsule of the tumor on the upper part, and then go to the left side first. And then you're going to see in the video how we had some strategies for that.
Thank you so much, JP.
My pleasure.
I'm just gonna move to the T2. Okay.
I think maybe the T2 will give a sense of, the vessels and the carotid and the intimate relationship between those vessels, and right there, beautiful, right? You can see how the tumor, and you're gonna see that actually. That carotid, you see, you can imagine the 3-dimensional. Yeah, beautiful. I like the way you're going back and forth, because that's exactly what we saw. And I love, JP's strategy to taking this tumor, because my impression, I was planning to go after the second component first. And he said, no, we should go after the first component, which is the cavernous sinus. And I'm thinking, well, that my thinking was at the time, I want to go for the component that we can decompress the optic nerve at first, because once again, is the concern of getting to the cavernous sinus. They said, well, once we do that, it'll be more challenging to go after the component of the cavernous sinus. So he convinced me to go after the component of the cavernous sinus first, which I think it was the right decision, obviously, because then after that, we were free to take out the second component, which is when everything collapsed. And then at that point, you're done and you can get out of there. But that's beautiful, intimate detail. But you can see my concern about going to that component is the intimate relationship between the tumor and the carotid artery right there. Beautiful. I love the way the sagittal is showing the carotid right there, because we're going to see that in the video.
Yeah, keep it right there for a second. I fully agree with Dr. Q. This is a beautiful image here. And when you see here, this is the horizontal segment of the ICA. This is the anterior genial horizontal segment here. And then what you see here is that tumor that is going to be located above the horizontal ICA, and this component that extends a bit posterior, but I wouldn't yet call like in the so-called posterior compartment. But that's why I particularly like to call one single thing as a posterior superior space in the cavernous sinus. So we know that when working in this corridor, we're going to have to work likely from medial to lateral and angling our view to see all the way to the roof and the aspect above the carotid. And that's what we're going to aim to have in the surgery as well. Please go ahead, Luisa.
All right. So here we have the CT scan. We're just going to start just playing all of them because this patient had a previous intervention. So this one is going to show us a different anatomy as the one that we saw before. A different bone component that's already open. So I'm gonna just keep moving forward. So differential diagnosis for this case is a pituitary adenoma, less probable diagnosed pituitary lymphoma, meningioma, craniopharyngioma, and pituitoma. As always, we like to keep a differentials very open, particularly with collision tumors. Assessment and plan, an extended endoscopic endonasal transsphenoidal approach. Other options will be observation medical treatment, a stereotactic surgery that's usually reserved to patients that are in a more critical state and other circumstances. And open transcranial is another option, but this patient has a already open kind of pathway and also have people that is opening the new horizons in the endoscopic endonasal approach. So the team were feeling very comfortable. The plan will be obtained tissue for diagnosis, achieve a maximum safe resection, and illness control and management. So I'm gonna avoid the question for now. However, I'm just gonna put it right here because it was the component of the superior wall, the cavernous sinus includes everything, but this is the optic nerve is not part of the cavernous sinus. So I just spoiled the answer. So potential risk and complications, Chase already spoke about this very beautifully. Is in this surgery in particular, the CSF leak is a very important one. So Dr. Donaldson actually was kind of prepared in case of the patient require a bigger repair. So let's start with the surgery right now. So you're just gonna, so we're here, Dr. Donaldson is infiltrating, it's on a pinner frame. So remember, the whole anatomy is already distorted compared with the previous surgery. So here we are seeing some exploration, some mobilization of the previous flap and the middle turbinate. We can see in the back how, well, she's preparing here part of the flap. And some of, well, part of the previous surgery, some scars, so removing of the previous flap. Now with Dr. Jonathan still in the call, I'm just keep talking
Dr.
about.
Johnson, yeah, she just had to leave, I think, to go to the OR. But you see here that she is mobilizing the flap, as Luis is explaining, and then that flap, which was harvesting the previous surgery, can be explored now. Can you go the same thing that Chase did, Luis, as well?
Yes.
Okay, you can stop for a moment. So you see here, like this is the cavity that we had from the previous surgery, right? So you see that it's somewhat classic midline approach. Of course, bone can mineralize laterally, so don't want to say that this is all that was open, but appears to be so. And then when we look at this, we have to think about, or expansion, what we have. So the first thing that we need to have is in the left side, we need to have more exposure. And then we need to think about where the carotid was. I mean, here, this specific slide doesn't show it very well, but I could tell that right here we would have the left optic nerve, and you're going to see the location of the paraclinoid ICA coming in this space. So let's just go ahead and continue with the drilling, and then you guys going to see how we went from there. So the exposure really is, I think, I don't know, probably 60, if not 70% of the surgery, because if you don't get the correct exposure, and in this case we needed to have the left carotid exposed, as you're going to see there, you see that we're moving towards the left clinoid segment, and then once again we need to have the right all the way to the medial wall on the right side, and you see that we went ahead and get all that exposed. Stop for a moment right there.
Sure.
You can stop right there. Beautiful. So what you see here, this is the carotid on the left side, and the clinoid segment will be here. This is already part of the anterior wall of the cavernous sinus. So it's not that you have the carotid here, but here you have the tumor extending into the cavernous sinus, okay? And then you're gonna see, as you can play the video.
Sure.
You're going to see as surgery goes that you had on the right side the fibrotic component that, or poor Caesars, they were too fragile. So we have to we bought more Caesars after this case, because the dura itself and all the fibrosis from the previous case was quite significant. And then we went ahead and opened the dura,
and there was an important move that you did there, JP, which was the Doppler. It was just briefly shown where he's understanding where the carotid is, and it was very fast that they showed, but it was beautiful right there because he was getting a sense where are the carotids laterally. So he was carotid to carotid right there. So we were working from, there you go, that was beautiful right there. So the Doppler was side to side, and we knew exactly where that carotid was. So that's perfect, both carotids.
Exactly. That's exactly the point that Dr. Q just mentioned. And in our point of view, like the Doppler just gives us a degree of safety that otherwise would be difficult to nearly impossible to do some of this surgery in the cavernous sinus, in our point of view. Okay, play. So same, techniques, mobilizing the dura away from the tumor capsule. In this case, it's a re-op, and you see that not really too concerned about creating a capsule. This is definitely not going to be a, pseudocapsular resection. So we have to create some space and create some debulking. But you see, pseudo, we try to go laterally first and to create and have an idea of how laterally this tumor is going to go. This is even before tackling the tumor. And then you attack the base of the tumor, so the most inferior component. And you see here with a straight dissector and suction, device. And after the bottom part of the tumor is debulked, then you can go to the cavernous sinus. So once again, with the Doppler, mapping and finding a safe space in the anterior wall. This is just mobilizing a bit the anterior wall of the cavernous sinus. And then with the feather blade, we go ahead and open that, that anterior wall. Then same maneuver as you saw in the previous case. And then you open the cavernous sinus and blood. And then you stop the bleeding.
And one important maneuver that JP does, and I've been learning, and if you go back to remember the sagittal picture that we're doing, the cavernous portion of the carotid comes from posterior to anterior, from inferior to superior. So notice how he opens, if you think about a clock, he opens anywhere between 4 to 6, you know.
Stop the video, Luisa, just so.
Yes, sir.
Thank you. I'm sorry, Dr. Q. I
Yeah,
just wanted to make
Right
sure.
there. Yeah,
Yeah.
it's perfect right there, because that's where you open, right? Right at the
Yeah.
bottom, between 4 and 6, you know, and that's a safe zone. But before that, because it's a redo and you cannot take anything for granted, he still mapped it with the Doppler just to make sure that everything was fine and we were going to be in a safe entry zone. I think that that's probably the safe entry zone is a way to think. Just like what we do for cortical surgery for awake cranial, you got to find a safe entry zone. And that's exactly what he did, even in a redo.
Yeah, this is exactly what Dr. Q said. I mean, and I really like the way that he explained when you mentioned 4 to 6 hours. That like I kind of like I explained that's I think makes it much easier, in fact, to understand. But the reason for that 4 to 6 hours of inferior is just because in the anterior wall, you have to remember that anterior gene of the carotid is going to be higher located. So quite often that's going to be around your 2 to 3 o'clock. And then that 4 to 6 is usually free. You have a pocket with venous blood in the cavernous sinus that is going to separate you from the carotid. Of course, you have to map because every case is every case, but that's absolutely the idea of the technique. You can play, Luis, again. Thank you. Yeah, I think we should have explored. So you see, Luisa, can you go back just a moment? I'm so sorry.
Yes, sir.
Just a touch. Go back a bit more. I just want to show, because it's the same technique we used in the previous case. Go back more. As we dissect the medial wall, that's what I want to show.
Okay.
Okay, play. So here you see that once again, same technique. Once you open the anterior wall of the cavernous sinus, you start to mobilize away. And then what you see in white, and Luisa, you can stop when you see the carotid there.
Sorry, I
It's
know
okay.
that.
It's okay. It happens.
Been too excited, but
Okay.
I know
Forward,
it's right here.
forward. No, it's a bit more forward. Okay, just play. It's fine. Just be mindful. Okay, and you see that with the dice.
Oh my God. No, it's I know exactly the point now.
Okay, perfect. So
go.
what we have right here is the horizontal segment of the ICA, and you see the color of the carotid that's more white, yellowish. And this is the medial wall that we are dissecting from lateral to medial. So you always dissect in this direction, okay? And as Dr. Q was saying, often from inferior lateral to superior medial. So you mobilize that away as you go. So keep playing the video. And then we do that. And as we do that, yes, we're going to open some venous channels. And when that happens, we have to go and use the hemostatic pounder again. And then we stop the venous bleeding. We make sure that we have the best image as possible as we do that. So you see that capsule, the membrane around the cavernous sinus is being elevated away. And you're going to have a better view in a moment. And then we are separating. Stop the video if you can.
Yes, sir.
Go a bit back just so we can see some of the segments of the carotid. More. Okay, right there. Perfect. So you see here, this is the horizontal segment. This is the posterior genu, and the carotid curves here. This is the ascending segment of the carotid. What you have here, what we're mobilizing, this is the roof of the cavernous sinus. And this is the medial wall going towards the posterior wall here. So because the angle that we have, we're looking at the roof already. And then remember that this tumor was going above the the horizontal ICA. So that's why we have to mobilize it like that. So let's keep playing.
Notice as they keep going, you saw the narrow window of 4 to 6 p.m. where we opened the cavernous sinus. It's so small space, and that's why JP was also, mapping with the Doppler. But it's a beautiful illustration right there of the safe entry zone, which is only literally like 3 millimeters. All right, so you got to be extraordinarily careful. And this is what Gabriel was saying, not everybody enters that space. You have to be very confident. You have to understand the anatomy and use the Doppler more than the surgical navigation. Actually, we rarely use the surgical navigation in that space. It's just the Doppler, mainly in knowledge of anatomy.
Yeah. And then after we explored the cavernous component, then we went back into the the so-called cellar component, and we started cleaning that tumor as well above the medial wall. And then we working medial and lateral, but this you saw there already. We had the carotid crossing this way, so that part was clean. And then just going up superior laterally, now going from medial to lateral rather than from to back, all the way until we got here, which is the diaphragma, and that part therefore was clean. After we finish with that part, then, I mean, not finish, we continue to explore here. We continue to explore. I believe we get a 30-degree scope at some point.
There was a little bit of tumor hiding in that corner, remember? I think that
Yes,
you kept
exactly.
chasing it, yeah.
Yeah, that's absolutely true. Yeah, I think we show this. Just keep playing for the sake of time, Luisa. But you see, we're working here, and then we're trying like crazily to get this component.
But notice that it's beautiful because not the other component on the patient's right-hand side hasn't fallen. I mean, if we would have done with my approach of removing that, everything would have been obscure. There would be CSF now dripping potentially. It would have been a very obscure, a narrow corridor to work in the cavernous size. Right now, the same tumor on the patient's right-hand side
Well,
is
that's the
holding all that
component.
component. Yeah.
Yeah, that's the component you were talking about just now.
Yeah.
Yeah, so that's the component Dr. Q was talking that was
Beautiful.
hiding.
Yeah, that's gorgeous.
And this is with a 30-degree scope now that we are looking up above the horizontal ICA, and you see us working on the roof of the cavernous sinus. And here you see with a feather blade to try to cut through this fibrous component of the tumor.
I think the video just cut part of it.
It's okay, no worries. I mean, and then what we did, I can share with the others later. What we did, this component here, we resected after that as well. And then we got the complete resection. I don't know, probably was something with the download that I shared with you.
Maybe.
It's okay, no worries. We can share that later. Okay, so let's go ahead.
All right. So pathology. So I'm just going to explain what Dr. Gentov. I think that you can't hear Dr. Gentov, so I'm just going to explain. He's saying that there is no atypia, there is no extreme mitosis. This is kind of very homogeneous. So the adenoma stands for the alpha subunit FSH. That is also found in LH or in other hormones. And also SF1, it's kind of a compound. So when we have both positive, it is this is suggesting us that it's a gonadotrope type of pituitary adenoma.
Perfect.
So, and then I'm just going to play this pre-op. At the same time, I'm going to play the post-op because the difference, and I'm just going to go back to the main image here to have a beautiful comparison of how it is the before and the after. So I'm just going to move back and forth. So this was a gross store resection. Also, you can see how the whole components are now decompressed. And with this patient, also you can see the beautiful optic chiasm over there.
And you can
Now
see the
suffering.
pituitary. You can see the pituitary stalk also, and the pituitary right there, beautiful. I mean, it's so thick because I was still a young patient, and it's just now engorged after we decompress everything. It's a beautiful resection, absolutely. Cavernous sinus clean. We missed the second portion of that video. Let's edit to that, JP, so we can put it in the archives, so that way people can see it in the future. Absolutely gorgeous.
Yes, it was beautiful. Also, in the post-operative course, it was uneventful in general, and the patient was discharged in the 24 hours post-op. It was very interesting because the patient, after he woke up, immediately he referred, I can see in my right side. So that was an important recovery right away. So now continuing with the follow-up, the first one was with endocrinology, Dr. Varsukova.
Yeah, after this tremendous surgery, like he actually has a pretty good robust, like cortisol, which didn't suggest that, like has any adrenal insufficiency. And then, like on post-op day, we see what he has still, like pretty, good, like pituitary axis, no really, like signs of the secondary hypothyroidism, and as well as, like adrenal insufficiency. I think they only know any growth hormone deficiency. Post-op, he developed DI, which we probably expected so after such surgery, but he was discharged on DDBP, but only took for 2 days and then actually improved at that point. And as I mentioned, it was non-secreting gonadotroph tumor, really didn't secrete, like.
Thank you, Dr. Varsukova. Also, the patient had a follow-up with Dr. Quinones, so the patient was doing perfectly clinically, no sign of CSF, infection, leaks, or anything. Now there's going to be a next follow-up. And with the ophthalmology, he had an appointment the 12th, and we can see the big change in the temporal visual field. Of course, it did better in the inferior part than in the superior part, but so far, if we compare with the preoperative one, it's a beautiful change.
Yeah, this was really nice to see, just because he had lost so much nerve fiber layer before. His chances of improving field were not great, but despite that, he did extremely well with this decompression.
I just want to mention for Dr. Egenberger that what a great pleasure it is to work with you and Dr. Pless. I mean, it is always amazing, and to just get these quick follow-ups and everything. And of course, the reason why that patient went home the next day, same deal as was said before, because Dr. Sampson follows them so closely as an outpatient. So she and her team share, take all the burden of following them closely. But this is an amazing follow-up. And thank you also, Eric, for getting me into clinic the other day to get my own eye examination.
Anytime.
I was in the waiting room, and then Eric was walking and he sees me there and he goes, no, come on, let's go. Let's make sure that they get you taken care of. So it pays off to have good friends.
Those are important eyes.
Beautiful.
All right. So now to finish the whole presentation, the title that I chose was because, as Dr. Wiener said, this is a new horizon. Even though the cavernous sinus was described years ago, the first time in 1695 by Ridley, described as a circular sinus. It's a space of leaving no room at all for either blood or serum to be contained there. He noted that it regards this relation with the artery and what was surrounding the pituitary gland. The first description just said there's just the artery and just the sixth nerve inside, and that's it. Later on, it started to show that also the sympathetic plexus and all the venous plexus and some other dissections that usually just include wax and other kind of feeling to the vascular bed, just show us the whole relationship of how beautiful the cardinal sinus and how important and dangerous it is at the same time, thanks to Thakur et al. And nowadays, we are able to see this. We just moved from the cadaveric dissections in the days without any contrast, with any wax, in any preservation technique, to a view with endoscope, to a view with beautiful preservations from above, from below, also, as is this case. And of course, Dr. Almeida just had to give a surgical pearl in his article. It was very nice and very interesting to learn this anatomy. And I have a last question. I will keep it there. I don't know if you want to answer mentally. And finally, this photo, because I took this photo in this surgery. And this is everything: mentorship, knowledge, teamwork. So I love it. It's one of my favorite photos. Finally, I just want to say thank you.
Oh,
Beautiful, Luisa.
Thank you. And once again, Luisa, it's her last official day with us here, but it's been a great pleasure to work with you. And you're not only like professionally very good and very talented, and I think we're all sure that you're going to do very well, but in a more important level, you're a fantastic person, a very good friend, married to someone who knows how to bake bread very well, and bribed me with dulce de leche. So I'm going to miss you, and thank you very much for everything.
Thank you, Luisa. We enjoy having you, and it's been an absolute pleasure. I will miss you. I think I told Paola. Well, Paola will also miss you because we know how hard you guys have been working on the laboratory, and everybody here has benefited greatly from your friendship, from your knowledge, from your passion. So we're very blessed to have you. But you have friends. You're not going far from home. All right. Very good. So do we have a wonderful, and this is Monday. Let's see, what do we have? Carlos, Andres, what's happening on Monday?
So on Monday, we have Dr. David McCracken. He's a neurosurgical consultant at the Department of Neurosurgery in Piedmont Health. This will be a face-to-face meeting that we'll host here in Van Buren in room 1600. It will be limited to the consultants, residents, and fellows, but everyone is welcome to join us online as usual every Monday morning.
And this is the role of the neurosurgeon in the operating room to fight brain cancer at the time of surgery, by the way. And I think it's important to put it on, maybe change the title a little bit, Diogo. The role is cesium, because I don't even know what cesium 131 is, brachytherapy, formalin, is the role of the neurosurgeon in the operating room. You know what I mean? It's because that's exactly what it is. He's going to be talking about when you do surgery, what should you do? What kind of therapies you have? And one of them is this therapy where you can actually leave radiation therapy at the time of surgery in the operating room. So very, very important. So everybody join us. Hey, Gabriel, everybody, thank you. So your comments, thank you, everybody. You guys are wonderful. And Luisa, wonderful. And Chase, great work. And this is Dr. Sampson probably already. Thank you, Gabriel. Dr. Sampson already, and Julie already, are up and about in the clinic. And JP and I, we have to do a couple of surgeries today. We got to pay the bills. So thanks, everybody. Have a great weekend. Bye-bye. See you guys on Monday. Bye-bye. Adios.
Bye-bye. Bueno, espere, ¿qué vamos a hacer? ¿Qué vamos a hacer? ¿Quién dijo que salones no hay? ¿El secretario de qué? Tomen estos cables.
All right.
Hey.
Chase, we were wondering if you could please present the first part of your presentation, just like the clinical presentation, because we started recording a little bit.
Of course. Do you know Did you guys get the like the MRI imaging up to that point, or like Barsakova's comments on
We
the
started
labs?
since the CT.
You started with the CT.
Yeah.
Okay. Okay. Do you want me to do Dr. Barsakova's part? I could probably. Like, in
Yeah,
terms of the
just like
labs.
very brief. Mhm.
Okay, sounds good. Let me share
And
my
then
screen.
Adrian Safa, who is the one uploading the presentations, he can readjust. Mhm.
Gotcha. Can you guys see my screen?
Yeah.
Okay, and I will move this out of the way real quick. Okay, just let me know. Can I just start? Okay. Good morning, everybody. Thanks for joining us this morning. Let's get started. Before we begin, I would like to acknowledge all the wonderful surgeons and physicians who took part in taking care of our patient this morning. Everybody from neurosurgery, ENT, endocrinology, neuroradiology,
Something happened
neuropathology.
with your audio.
Can you not hear me?
Oh, we can hear you now. Sorry.
You can hear me now? Okay. I guess we can do a take two then. Good morning, everybody. Let's get started. I would like to acknowledge everybody from neurosurgery, ENT, endocrinology, neuroradiology, and neuropathology who took part in taking care of the patient we are presenting this morning. So our case is focused on a 53-year-old female with a history of osteoporosis who presented to the endocrinology clinic with a non-traumatic stress fracture of her right foot. She describes no inciting event that caused her injury. She did note that she returned to work part-time and has been on her feet more than usual. However, this wasn't related. It is important to note, like I said, that she does have a history of osteoporosis. In 2015, she had a non-traumatic stress fracture of her pelvis. In 2016, she had a non-traumatic stress fracture of her left foot. Since that time, she was treated with a variety of bone reabsorption inhibitors, the most recent being Fosamax, which she was on while she experienced this current stress fracture of her right foot. Additional initial complaints she had was generalized fatigue, weight gain greater than 10 pounds, which she felt was more pronounced around her waist rather than in her extremities, muscle pain and stiffness, easy bruising and bleeding, frequent headaches, and decreased libido. Besides her history of osteoporosis, she does have a history of invasive ductal carcinoma of the left breast, which was treated in 2020 with surgical resection and radiation therapy. She also has a history of generalized anxiety disorder and major depressive mood disorder. Her physical examination was pretty unremarkable. She did have a elevated blood pressure on exam, and this was unusual for her as she does not have a history of hypertension and she has never been treated with any antihypertensive agents. Generally, she had some facial fullness with some mild redness, and her neck had a prominent dorsocervical fat pad. So given her most recent non-traumatic stress fracture while being treated with Fosamax, the endocrinology team here underwent an investigation for secondary causes of osteoporosis. Common causes are listed on the screen. The endocrine disorders are what we are most interested in here, and they include Cushing's syndrome, hyperparathyroidism, hyperthyroidism, and acromegaly. Given the patient's weight gain more pronounced in the waist, her hypertension, her osteoporotic fracture, her headaches, and the facial fullness in the dorsocervical fat pad, this is painting a cushingoid appearance. So this could definitely be at the top of our differential. However, the patient was taking letrozole, which is an aromatase inhibitor, and that has been associated with secondary osteoporosis. And she was on this medication for her history of estrogen receptor, progesterone receptor breast cancer. So the first question that I would like to pose is, given her cushingoid appearance, which of the following lab results are suggestive of pituitary dependent Cushing's disease? And if you haven't already, you could scan the QR code, or you can text Mayo Clinic, Mayo, Florida 165 to 2233 to register. And the up and down arrows are just over secretion of cortisol, under secretion of cortisol, ACTH, up secreted, down secreted, elevated blood pressure, decreased blood pressure, hyperglycemia, hypoglycemia. Okay. So her initial lab work was pretty unremarkable. She initially had a CBC and BMP, which had no abnormalities, and it's important to note here that her calcium was within normal limits. She did have an elevated total vitamin D. However, the patient does have a history of osteoporosis and was taking over-the-counter vitamin D supplements. So we would expect this to be mildly elevated. Her PTH was within normal limits, as well as celiac tests, including IgA and tissue transglutaminase antibody IgA. Both those were within normal limits. Her tryptase, which is a marker that investigates for mastocytosis, was within normal limits. Her thyroid function panel was within normal limits, and her IGF-1 was within normal limits. A few weeks later, she had adrenal and pituitary labs done. And here we can see the results of her overnight 1 milligram dexamethasone suppression test. Her cortisol level was markedly elevated. We would like to see for appropriate dexamethasone suppression a value of less than 5. Here it is 15, so that's markedly elevated. It's also important to note here that her ACTH was elevated at 66, and we would like to see for it to be an ACTH independent mechanism, this value being less than 20. However, since her ACTH is markedly elevated, this is a clue that her hypercortisolism is a ACTH dependent mechanism. This is also supported by the fact that her serum DHEA is elevated, which can be seen in ACTH dependent Cushing's disease due to constant stimulation of the adrenal gland by ACTH. Additionally, her prolactin level was elevated, and this can be seen in pituitary adenomas due to destock effect. And finally, her diagnosis was confirmed with an elevated 24-hour urinary cortisol at 150 and with normal creatinine and an appropriate total volume. So given her apparent ACTH-dependent hypercortisolism, on labs, we obtained a MRI of the pituitary to investigate for any possible pituitary masses. Here are the T1 weighted MRI images, and these are both contrast. On the right is the coronal view. And on the coronal view, if I could stop it right, here you can see a slightly hypoenhancing mass on the left aspect of the pituitary gland. It's intracellular. There is lateral extension past the tangential lines of the cavernous and supraclinoid ICA, and this is suggestive of cavernous sinus involvement. Additionally, if we go back to here, we can see that there is rightward deviation of the pituitary stalk away from the intracellular mass, which is typically consistent with a pituitary adenoma. And given her elevated prolactin levels on her lab, this finding corroborates her lab values. Additionally, if we look at the sagittal view, there is no compression on the optic chiasm, and the mass does not invade into the supracellular space. Here we can see, this is the T2 weighted image, and if we go, and this is coronal, here we can also see a little bit better outline of the image at its greatest, the intracellular mass at its greatest diameter. It measures 1.5 centimeters in diameter. And it's also important to note here that both the cavernous segment of the ICA and the supraclinoid segment of the ICA are patent and have normal flow. And I think this is where you guys picked up. Am I good to stop? This is where you guys started recording. Yeah.
Thank you, Chase.
No problem.
Thank you very much.
No problem.
See you here.
Okay, take care.